Terrific. Well, welcome to our third webinar for the equity bundle. So exciting to continue to have this underway. Excuse me. Just as an update, it's exciting to report that we are one of 26 states funded by the CDC to do this work to ensure that there's advancement of maternal and neonatal equity action across the United States. And so it was really nice to have recently attended the CDC meeting to review and to discuss what other states are doing. So it's nice to know there are other states working on similar maternal goals when it comes to equity and how much we've been able to accomplish. And so exciting. So I want to say thank you again. Excuse me, for the participation and attention, and exciting for the holidays to be able to share and celebrating this with each other. All right, let's go to the next slide. And then here it is. Happy holidays to those celebrating. We will post this webinar on our webpage at the end of this. So anyone on your team that's not able to be present, if they would like to review or view these slides or this presentation, the recording and the slides will be posted. All right, next slide. So for those of you who are just joining, please type your names, institution to the chat. We have everyone usually stay muted. And then what we do is have everyone unmute or raise their hands when you have questions and like to speak. So we'll be excited to review a few things with you, our baseline data, a poll question, and then we'll go into our presentation with Dr. Ireland. So without further ado, we'll go to the next slide, introduce our team. Again, we'll go to the next one, yeah. So this is our team. So thank you to everybody who's part of our maternal equity work group. And so it's a number of faces on this page, but we're always welcome to more joining. So if those of you who are interested would like to join our maternal equity bundle work group for PenQuin, please let us know and email Kaylee Vitek at admin@penquinma.org. All right, we'll go to the next slide. I think I just said that wrong, Kaylee, in terms of your email address, but we can put that in the chat as well. So here are the hospitals across the state that are participating in this bundle. We do have 19 hospitals that are engaged, which is exciting. A number of them, of course, toward the east, and we do have our representation in Springfield going toward the west. So thank you. And the goal would be that over time, we continue to do more with this particular bundle, but then also include more hospitals. So if you have partner hospitals that you work with that may be interested, let us know. We're happy to schedule a coaching call and get them up and running as well. Next slide. All right, let's go over some data. So again, we'll continue to go over the structure measures. The data that you submit, they're all due on the 10th of the month. That you'll see the link from BLC REDCap come out on the 1st of the month. What we want to do is assess the structure and process measures together. I know since up to this point, we haven't gone over the process measures, but we're waiting until we have a critical mass amount of information to be able to review and see where we are. We do have the OB-RN or OB-MD champion fill out the survey and complete those and send them in. Those are done with a signed memorandum of agreement. So if you have any questions or needs, you can also reach out to Kaylee Vitek to discuss supporting an MOU with the Betsy Lehman Center, who is our data center. So of course, as always, want to say thank you to the Betsy Lehman Center for supporting us. When you go to the next slide, what we'll talk about for a second with these submissions. I am so sorry, just having a moment. If you want to go back, actually, Kaylee. Yeah, what we'll do with these submissions is there is a new Likert scale. So as folks answer questions, many of you are already aware of it and using it, but if you have any questions about what number constitutes where you are on the Likert scale, again, you can reach out to us. We're happy to set up a call or answer by email. Also, importantly to know, as we continue to develop and build out these measures, there are some that are having a difficult time answering the survey overall because there may be a challenge that they have with, for instance, the diversity of roles for, I'm sorry, not the diversity of roles, but when we're answering the question, the process measures around the bias training, then we look at the different roles. Sometimes someone would include their OB anesthesia, and sometimes they're not including OB anesthesia. So we may add a radio button. So that's to be determined in the near future. So we'll come back to you with how we'll manage that. But for those of you who've had any challenges, because there are certain types of providers that weren't included or were included, we want to be able to provide that opportunity for you to answer the question easily. But in the meantime, you can just put comments into the comment section at the end of each question for structure and process measures. All right, we'll go to the next slide. So to help us with thinking about data as we move forward, our next webinar in January is looking at real data dashboards and real data utilization. We'd love for folks to type their answer into the poll that's populated on the screen. And that is, what EHR do your teams use? There's Epic, there's Centricity, Cerner, and maybe other. And if you have other, please type what the other is into the chat. Perfect. So if you can see the poll, it should be right on your screen to answer. And if you're on the phone, you can answer into the chat as well. Terrific. Looks like we're slowing down on answers, so we'll stop the poll from there. And we're sharing our results. Can others see the results? 70% seem to be using Epic, and there are some additional EHR systems listed in the chat. All right, we'll go to the next slide. Thank you for that participation. That's helpful.
Yeah, this is very helpful. Thank you, everybody.
All right, so let's look at these structure measures that we have. And as you guys remember, there are 4. We look at whether or not you've formed an equity team, and do you have equity measures that you're working on together, or equity goals, I should say, that you're working on together, and what those types of goals would be. And then we also look at your engagement with PREMS and your real data dashboard. So we'll lean in a little bit more still on the equity team formation, especially with our talk today. So in the question we've asked, do you have a formal equity team based in OBGYN? And now, as of November, we do have 9 hospitals that have answered, and of the 9 in November, 5 have a formal equity team. So I think that's terrific. We'll go to the next slide. As others, maybe developing theirs, we also ask the question about, when you're forming your equity team, or as yours is already developed, do you have a diversity of roles? Do you have a diversity of race, ethnicity, and do you have any community members on the team? All equity teams are progressing toward diversity of roles on their teams, but no team yet has any community members. Let's look at the next slide. In asking the question about obstetric equity goals, we want to know, are you working on a SMART goal? Do you have change concepts or driver diagram? Do you have an anti-racism statement? And think of the anti-racism statement as just simply a statement of your hospital unit's values when it comes to serving your patients. And I believe we all share the same values of really wanting to offer the best care possible to everyone. And it's quite that simple. And how do we put that into a statement so that those who are experiencing the worst of the outcomes when it comes to SMM and maternal mortality understand that we acknowledge that, see that, know that's happening, and still continue to think about those things as we provide the best care on our labor units. 4 of 11 reporting hospitals in September, and 3 of the 8 that reported in October had anti-racism statements, but no one had change concepts. We go to the next slide. Yeah, and we'll have more information on the November as we update the data slides. In terms of the demographic data collection, so we're asking questions around what type of data do you collect within your hospital and on your labor unit, especially at registration for obstetric care and at admission for delivery. And then what types of demographics within that demographic data do you collect, and how much do you slice that data? So we're asking questions around, do you collect data on race, ethnicity, gender identity, language, sexual orientation, and differing abilities? And that's important because then when we have data and our outcomes, whether that be NTSV, C-section rates, whether that be QBL utilization or hemorrhage rates or timely treatment of hypertension, we want to be able to see what group of people are doing well and what group of people are having a challenge with meeting the goals of each of those particular processes. Of the 9 hospitals who responded in November, most collect that data. Everyone's still working on all versions of it. And that just becomes really important as well, because across the country, and one real strong focus of the CDC is to ensure that we help hospital teams develop the ability to collect data. And you go to the next slide. We also asked the question around, are you collecting that data through self-identification? And when you accept that data through self-identification, we know that you're getting it in the best possible way. And then when you have any particular processes on L&D, do you stratify by all of those categories? And as of November, of the 9 hospitals that responded, 2 stratify by all categories. But that would be the goal, is that you have an ability to just run a report, really. And we'll get there. Many people aren't there yet, but it starts with collecting the data appropriately by self-report, collecting the right variables or demographic identifiers. And so, for instance, another demographic identifier might be active military veteran status, because that may be different for others. And when we look at this data, then we're able to move our process and our outcome activities forward. And so it becomes very important to think that way, because not everyone has a disparity by race and ethnicity, but there may be disparities definitely by geography, which is not listed here, but geography would be part of that, as well as by language. All right, let's go to our next slide. So, when you're looking at these slides visually, the goal is that we're going to see mostly blue. And right now we're getting closer to that. And just to update those who haven't been on the calls recently or before, the colors are what they are, so that we can be those who have any deficits in their ability to see red and green. We put them in colors that are more apparent and able to be viewed by all. So that's why you have these color schemes. And the goal, again, is blue. And so when we think about PREMS, which is our additional measure, that is a structure measure, we want to know about patient-reported experiences. And that's become an interesting conversation, because many of the responses we've gotten in terms of what types of measures people use, they may use systems where, like HCAHPS, et cetera, where they're getting satisfaction scores, which could be a way to measure patient experience. But the overall goal of looking at patient-reported experience measure is we understand and learn that when it comes to many of the disparities, people who are giving birth on labor units at times report feeling not seen, not heard, not a part of their team, and not having their pain treated in a timely fashion. And with that, we want to make sure that we have an ability to learn what's happening on our labor units, what experiences patients are having, and ultimately, one phrase that we really want to tout is respectful care. And so your PREMS should be able to help you measure the experience of respectful care on your labor units. So in November, we see more blue actually on the screen. And so that's really exciting. When you go to the next slide, Kaylee, in your comments, many of you have told us what types of PREM or patient-reported experience measures you're using in HCAHPS from CMS, as well as Press Ganey are the 2 most common. Those of you who are engaging in working with Team Birth, we have a PREMS that we have created and adapted from the Madam and Mori scales, which were validated questionnaires that we've brought to Team Birth. And so as hospitals implement Team Birth, they will also implement a PREMS that helps to identify and really get to the nuance of patient experience on L&D. All right, let's go to the next slide. And here's just some additional details. It's really helpful to get the additional details, because it tells us which direction to go in and how we can provide additional information to help teams on their journeys. And so we really love hearing all about what's going on. And so this is an example of what's happening utilizing an informal shared decision-making process, using PREMS through Team Birth survey. So we're getting some more information. It helps us to move this work forward with you all. I'm going to pause there just for a moment as we go to the next slide and see if there's any questions in particular related to the structure measures. I know we haven't gone into the process measures yet. Are folks sort of itching or waiting to hear and see? We have the process measures in the slide deck. We can post that even though we haven't reviewed it with you, if that's what you'd like. So I just wanted to sort of pause and get some feedback from the group on how you're feeling about the structure measures, because we're just really spending these first 4 months leaning in on creating those structures that allow us to be able to do the work of those processes so we can get the outcomes that we're looking for. Any comments for the chat, or anybody want to unmute or have any thoughts or questions? All right, I'm seeing none. So I will move forward. I have the pleasure of introducing our guest, Dr. Luu Ireland, who is the Director for Diversity, Equity, Inclusion at UMass Memorial Health Center. She's going to talk to us about their experience on equity teaming and their goals and how they established an anti-racism task force and an anti-racism statement for UMass Memorial for their patients. And so without further ado, I'll turn the microphone over to Dr. Ireland.
Thank you so much for having me. I'm just going to take a minute to share my slides. Oh, Dr. Meadows, would we, or Kaylee, would we be able to stop sharing this slide so that I can share my slides? Thank you so much. All right, can everybody see my slides okay?
Yes, we can.
All right, wonderful. So before we get started, I just wanted to take a minute and, oh, my slides are advancing without me. Take a minute and extend my appreciation to Dr. Meadows and the entire Pinkwin team for this opportunity to speak about the work that we are doing at UMass. These are my disclosures. I have no financial disclosures in relation to this presentation. I do want to stop and acknowledge that this work is not easy, and none of us come to this work being equity experts and knowing how to establish equity right off the bat. So I very humbly want to acknowledge that this is a work in progress. We are by no means doing things perfectly, but we are working hard and driven with a passion to promote equity and justice in the healthcare that we deliver. All right, so we started this work back in 2020. Like many of you remember, that was a time when there was a lot of growing public discourse around Black lives lost at the hands of police, including Breonna Taylor and George Floyd. There was also growing public discourse around Black maternal mortality and morbidity, including, the episodes with Serena Williams and her experience in postpartum care, Dr. Shanice Wallace, who died of HELLP syndrome during her first delivery. A lot of our work was catapulted by the change in public discourse and attention really highlighting the different healthcare and life experience of Black individuals versus their white counterparts. At the same time, we started looking at our own data through NPIC, and we, notice that we are not immune to those inequities as well. So many of you are familiar with this chart. You can see this column here for our Black birthing patients. On almost every marker, we have worse outcomes when it comes to postpartum hemorrhage, ICU stays, severe maternal morbidity, preeclampsia and hypertensive disorders. Our Black individuals and our Hispanic individuals were doing worse than their white counterparts, and we were highly motivated to investigate this and address this. All right. So our group started very organically, and it really was a fortunate aligning of events. So a group of faculty and residents, including myself, reached out to our department chair on the need to address racial equity at our maternity center. At the same time, there were a lot of conversations among nursing around racial equity and maternity care. So nursing leadership was independently having these conversations, and I'm happy to see some of our nursing leaders at UMass here on this webinar. And at the same time, our chair had just connected connected with Dr. Nicole Christian Brathwaite, who is a psychiatrist in Massachusetts who consults on diversity, equity, and inclusion and serves as an anti-racism consultant. So the group of us had our first meeting in June of 2020. It was a group of about 15 of us. We had several OBGYN faculty members, residents, our department chair, and several members of nursing leadership. And we, that was the first opportunity where we said, this is a group that has shared commitment to improving equity in the healthcare we deliver. And it was the first step in an ongoing relationship in which we worked as a team to address these issues. Out of that first meeting, we had 4 initial goals. One was to establish an anti-racism task force, which would take on dealing with racism and bias in maternity care. And we really wanted to make sure that this group was multidisciplinary and had representation from all the folks who work on labor and delivery. So out of this meeting, we reached out to family medicine, reached out to social work, and broadened the scope of folks who are participating in the work. The second goal was to come out with a statement of a commitment to racial equity in maternity care. And we really wanted this not just to be a statement for staff to see, but we really wanted it to be patient-facing as well. The third goal was to come up with a department survey. We knew that we had problems with equity. We had long heard about issues about bias, discussions about microaggressions, but we didn't know where to start in our work, and we didn't know which issues were the worst. So we really wanted to start with a survey to target our initial works. So that is where our relationship with Dr. Christian Brathwaite was really helpful. And I'll talk a little bit more about how that survey was launched. And then our fourth goal was to put together a maternity center town hall. We really wanted a public forum and space where we could bring the entire maternity center together to educate folks about equity and maternal outcomes, and also present the findings of our survey so folks could get both a global view and a view of what things are like at home. So first, with our first goal, just establishing ourselves as a task force, recruitment really happened through email, through flyers on labor and delivery, but really through word of mouth. So one of the benefits of having representation from all the different specialties that provide care on labor and delivery was we had a lot of voices talking about our group and inviting other members to participate. You can see the representation that we had was very multidisciplinary, or have, I should say, it was very multidisciplinary. And we started by having monthly 1-hour meetings via Zoom. This was, at the height of the pandemic, and in-person meetings were just not possible. The number of folks at each meeting, has waxed and waned depending on what is happening in the year and what is happening in life. But our largest meetings were up to 40 people. This group became a really safe space in which people could learn about and discuss race, discuss privilege, and discuss our role in advocating for equitable care for patients from marginalized communities. We did a lot of education. I will say that while our patient population at UMass is very, very diverse, we have a very large immigrant population. I think 30% of our patients identify as Hispanic, 20% of our patients identify as Black. We have a significant non-English speaking patient population. while our patient population is very, very diverse, our caregivers on labor and delivery, nursing physicians really is not. So we had a lot of education to do. So we spent a lot of time in these meetings talking about what racism looks like, what are microaggressions, how and why are Black women and women of color being harmed more during the birthing process than white women. We talked a lot about white privilege. This space also became a group in which we could talk about experiences that we were seeing on labor and delivery, whether it was with patients or whether it was between staff. It was really helpful for us to talk about experiences and strategize on how to better deal with these instances as well. So there was kind of like an upstander training component to our meetings. And then we also did a lot of strategizing and planning about what kind of work we want to do ongoing. And we will get to some of that as well. When it came to our statement of commitment to equity, I will say our process felt very easy given folks all the way up through leadership of the medical center were highly motivated to respond to the crisis of Black maternal mortality and morbidity at the hands of healthcare and law enforcement. So we started off just writing a draft. We did look at other documents from other institutions to get ideas on how we wanted to compose this. This document was then edited by all the members of the task force. Everyone gave feedback. And when we had a first draft, we sent it to our chair for review. And then ultimately, it did need to get approved by legal and by hospital administration. So, you know, as often happens when we're going through hospital administration, things got a little bit watered down, but we were very happy with the ultimate message of the statement. Once that statement was finalized, we really wanted to inaugurate it with a public event, both so you know, we could inform our patients and inform our communities that we were listening and we are trying really hard to do better. With that, we worked with our PR department to build up publicity. We planned a multidisciplinary presentation of the statement. And then we filmed and showed the revealing of the statement on Facebook Live. So if you can see our flyer, I gave the opening remarks. We had our hospital chaplain give a blessing. We had one of our labor and delivery nurses speak, and we had one of our family medicine attendings give the closing remarks. We had about 40 people attend. Staff from all different staff from the maternity center. In addition to coming together as an audience to listen to us speak, everyone also took turns signing the statement, which is now hung in our lobby where patients register as a check-in for labor and delivery. So this is a view of our statement. There are more signatures on that at this point. The third goal was really to launch that department survey. And we developed that survey in conjunction with Dr. Christian Brathwaite, who we were consulting with. Our department offered funding to incentivize folks to fill out the survey. And through the month of September, this survey was distributed through emails and flyers, as you see here listed on the slide. We had approximately 173 respondents, approximately 50% response rate. We gleaned a lot of information about our culture when it comes to DEI at the maternity center. And there were two issues that really stood out among everything else. And one was that we had very suboptimal use of interpreters for patients with limited English proficiency. And many folks reported ongoing and unchecked microaggressions while they were at work at the maternity center. The task force was really key in making sure that folks knew about the survey and completed the survey. Once we had collected these data, we held our maternity center town hall. And this was our first kind of public event where we brought together OB faculty and residents, family medicine faculty and residents, and as many nurses as possible to kind of launch, like officially kick off our anti-racism campaign at the maternity center. We had Dr. Christian Brathwaite give an excellent grand rounds on racism and maternal health and healthcare. We had about 150 attendees, which again is about 50% of our maternity center. In addition to the didactic teaching about the issues of inequity in healthcare, she also presented the findings of our survey. I think it's very, very common that we talk to colleagues and they say, yes, there's definitely racism in healthcare, but it doesn't happen at our institution. So when we combined this with our survey results, it was very, very compelling. We have continued to work as a task force on a number of different projects since that time. And I'll just kind of briefly go over some of those projects. So when it comes to specifically addressing inequities for patients of color, we have held faculty and resident-wide implicit bias trainings. We have significantly expanded interpreter services. Our department has purchased a number of additional video iPads for interpretation. We had department-wide staff training on how you can best use an interpreter, and really been constantly reinforcing that interpreters should be used at every encounter, because it's not just about we as caregivers being able to communicate to the patient, but it's also about our patients feeling like they have a space and a voice to communicate to us. Our residents kicked off a core curriculum on anti-racism topics for the residents. And then, one of our proudest achievements was last spring, we kicked off a community-based summit on racial equity and maternity care. So, I won't spend a ton of time talking about this, but just to kind of briefly highlight what it was, is we spent about 6 months reaching out to community members who serve patients that are cared for at the maternity center. And we started the process of building relationships. We held a summit in the spring where we brought together hospital leadership and community leaders. And we really treated it as a listening session where we could hear from our community partners what we were doing well as an institution and what we were not doing well. So that was really eye-opening. It was really helpful to have our hospital leadership there. It really reinforced that we needed their buy-in and their investment in order to make real change. These relationships are what we're hoping to use as a basis of future community engagement as we roll out the equity bundle. We started equity M&Ms. We started both having an equity discussion at every single one of our department M&Ms. And then for a select number of cases in which a poor outcome was a direct result of equity, we've also had M&Ms that are entirely focused on a patient's identity and how that led to suboptimal care. And then, I did see some folks from Ariadne on the call. We also launched our Team Birth Initiative. So we really felt like the model of shared decision-making in maternity care, our goal was really to elevate the voices of all of our patients, including our patients from marginalized community, and make sure that they felt autonomy and they felt like they had a voice in their care. Other things we've done to just improve our culture of diversity and inclusion, we have continued anti-racism-based department education through a series of grand rounds, topics at different faculty meetings. We have completely changed the way that we hire faculty and the way that we do, recruit folks for residency. Many folks in their academic programs are talking about holistic review. We are doing holistic review as well. And we are truly trying to take that mentality and apply that to our faculty hires as well. Because as I mentioned at the beginning of the talk, diversity is something that we really need to improve at our maternity center. We really wanted to also develop a culture of inclusion. The last thing we wanted was to improve diversity and bring folks in from marginalized backgrounds to a place that felt hostile. So we have also rolled out a formal mentorship program in which we have a cadre of mentors who undergo bi-monthly trainings with our DIO department on how to be effective mentors and how to be mentors to all individuals, even folks who come from different backgrounds than we identify with. And then we have been working very hard with the medical center at large and with the medical school to collaborate on anti-racism initiatives system-wide. I did want to go back to our original slide looking at the data because I wanted to talk a little bit about some progress that we have been able to see. We have a long way to go. And, I cannot say, my research brain says I can't, association is not causation, but we are hopeful that we've seen some improvements. So this is our 2020 data that I showed at the beginning of the presentation. And then this is our 2021 data. So we can see that if we look at the outcomes for our Black birthing patients and our outcomes for our Latinx birthing patients, we still have an inequity there. That has not been erased, but we have been able to improve outcomes when it comes to severe maternal morbidity, when it comes to postpartum hemorrhage, when it comes to preeclampsia. So we're encouraged that we're headed in the right direction, although we have a long way to go. I did want to acknowledge that this work has not been easy, and we have certainly faced challenges and continue to face challenges. I think one of the hardest pieces of doing this work has been figuring out a constructive way to deal with microaggressions. I think that is a challenge that we continue to deal with. It has been pretty straightforward to do department education on the faculty and resident level. It's been much more challenging with nurses because we have so many nurses on our labor and delivery unit. We have over 200 nurses, and it's been really challenging to go beyond, e-learning modules and really give people meaningful training. There's also been, we're coming out of a pandemic. We are short-staffed, and there's been waxing and waning participation and competing departmental priorities. But I am happy to say that we are still committed to this work, and this work continues despite these challenges. In terms of future projects, we have recently received donor money to launch a doula program for birthing patients of color, and we are collaborating with a community-based doula organization to do this work. We are super excited about this project. We are building on our work from the summit to build a community advisory board for the maternity center. We are super excited to be rolling out the AIM equity bundle. We have recently, out of our task force, put together a maternal morbidity and mortality review committee. We are going to be The first two data points we're going to be looking at are ICU admissions and folks who require the massive transfusion protocol. All of those cases will go to our committee, where we will review those cases with an equity lens. We are going to expand implicit bias training, and we are working to improve our data collection and monitoring. We're doing a really good job of collecting data by race, ethnicity. We are not doing so good a job at collecting data by gender identity, sexual orientation, or ability status. So those are things we are trying to improve. We are also kicking off a multi-center study with a PCORI grant that's going to be looking at the impact of proactive monitoring of blood pressure, home blood pressure monitoring, and mental health postpartum for those marginalized by racism. So primarily our Black and Hispanic populations and our folks of lower socioeconomic status. We are going to be utilizing community health workers to visit folks postpartum and see if we can impact and improve some of these outcomes. That is all I have to present, but I am happy to take questions and feedback.
That was terrific. Thank you so very much. There are so many questions actually in the chat. Let me just start with the first from Dr. Job that asked, did you think about adding patient representation to your task force?
Absolutely. Absolutely. And that is still a goal. When we first started the task force, we, even though we're the biggest healthcare system serving the Worcester community, we didn't really have many real community relationships. So that was the goal of our summit. And we're in the process of trying to solidify those relationships and figure out where it makes sense. We really would love to envision a community advisory board. We really want to make sure that we are not taxing community members to participate. We want to be able to compensate folks for their time, offer things that make it easier to participate, whether it's Zoom or offering childcare. So patient representation and community representation is a huge goal. We just haven't gotten there quite yet.
No, thank you for that. We're all in that similar struggle here at my institution. What we've done is we've started with a community organization advisory board because it's already the sort of day job of some of those folks like the Healthy Start leaders, the March of Dimes leaders, et cetera, or other organizations in the area to be a part of the maternal child health strategic planning to improve outcomes. And so we start there and then slowly filter in additional people because it likes that way. It feels like you can have those community conversations without so far overtaxing like individuals. So yeah, I'd love to continue to share notes with each other on that one.
Yes, please.
A work in progress. Another question came and with regard to the kinds of questions that were on the survey. And could you share the survey that you had, the DEI survey that was created by Dr. Brathwaite?
Sure, absolutely. I am happy to forward that to you, and just want to continue acknowledging her role in creating that survey.
Yeah, and what's important too is I'm curious if you were going to plan on doing that DEI survey annually or just to monitor progress.
So the original goal was to do the survey and do a widespread departmental educational curriculum on anti-racism topics. And the challenge we kept running into is how do we capture all of the nurses? We are hopeful that with the equity bundle and with the PCORI grant, now we're going to have new resources to make sure all of the nurses and all of the faculty and residents are trained. So I imagine after that's rolled out, we would like to redo that survey.
Yeah. So maybe not annual.
We want to do a pre and post.
Yeah, pre and post, that makes sense. Do you make the education for all unit nurses and providers mandatory?
So we have not been able to make it mandatory. We have had an implicit bias session that or webinar that was made part of their mandatory like electronic learning. I personally don't feel like that's real mandatory education because every time I get, curriculum of electronic things I have to go through annually. I just kind of go through it as fast as possible to get done. So I don't know how meaningful that education is, but we would like to have, real live discussion-based small group sessions where folks are really talking about and learning the information, and that we have not been able to do mandatory.
Yeah. I think that is tough. And so that though, what do you guys use? Is it called, is it Health Streams or what's your?
It's Health Stream.
Yeah. So from there, you're able to run reports on the percentage of your staff that have completed equity bias training.
Mm-hmm. Yeah.
Okay. Yeah, I think that I just wanted to point that out and state that out loud because I know it's one of our process measures. And so for any teams that may be struggling with how they collect that information, we've done something similar here. And I think that that really helps when you're in your learning systems, you can run reports for your department that show, the role and the person that's taken it and what percentage of your department has completed training, because it's easier way to also capture travelers and other people who are coming in and out of the department versus when you don't have that. When you have such turnover as we do nowadays on labor units, it becomes really tough to see what percent have actually trained. The next question we have is, we're getting lots of accolades. Thank you for your comments. And then there was a comment actually around an anti-racism statement, and I have a reply that I put into the chat. So just wanted to comment to Christian Pope, who asked about, the DEI statements. And, when I made the comment that your anti-racism statement is a statement of your values, I really love, Dr. Ireland, how you guys showcased that and had a reception for it and read it and made it live and really communicated that externally and not just being internally facing document. I want to just also put it on the table and say it out loud. This has made some people really uncomfortable. The concept of having an anti-racism statement, having the words be anti-racism. And so, I think the more we do it and the more time goes by, people become more comfortable because it just feels like, for me, and I, don't want to be glib in saying it, but it's no different from having a policy related to anything else that we do on our labor units. And so, our policy towards how we think about and value people, all people in the same way, also, needs to be depicted for those who we know have the worst outcomes. And just like we have commentary on how we manage, those who are, Jehovah's Witness when it comes to accepting blood products or what we will do, right? So it's our statement of value of how we're going to treat people. And so I just commented to Christian Pope that we did a session, an equity training session that we did 4 webinars, and it's posted on our webpage. And one of them is on anti-racism statements, and the Institute for Perinatal Quality Improvement are partners in that. And we talked about the 4 A's: acknowledge, analyze, act, and be accountable. And actually, a lot of us use the UMass statement. It was a highlighted statement for, replication and showing what those comments were. But any DEI statement, a diversity, equity, inclusion statement may not necessarily be an anti-racism statement, but the focus is on anti-racism. So anything that also in a DEI statement that acknowledges racism, pledges to act, offering action items and tangible or measurable steps to address and disrupt racism, and developing anti-racist policies or an anti-racist culture. Anything that announces that with the expectation of commitment from all employees would definitely suffice. But if the statement is just around having diversity of personnel, then that doesn't get to the action of what we're trying to achieve with anti-racism.
And that's such a fabulous point, Dr. Meadows. We were very intentional in using anti-racism, making an anti-racism statement and not a DEI statement, because our goal was not to make people feel comfortable. And we wanted folks to really wake up and see that this was an important issue. And this is a value that we expected everybody to abide by.
And we've provided the statement into the chat also. And we've also provided the webinar link into the chat. So available to folks, when you go to the next slide, we have some QI teaching that we always do at the very end. And so I just wanted to say and ask this question actually of Dr. Ireland while we have you. We like to do teaching on SMARTY aims. And so one of the structure measures that we saw is that many people have not yet accomplished the task of creating a SMART goal specific to equity. So we put into the slide deck an example of how you create a SMARTY aim. What do the letters stand for? Being specific, measurable, achievable, realistic, time-bound, inclusive, and equitable, and then what an example of a complete statement would be. And I just wanted to ask if you guys had done something similar, Dr. Ireland. I know you created the anti-racism statement, but did you have a specific equity goal that when you created your list of ongoing projects and activities? Were those based on a goal, or were they based on sort of the conversation of the group as to what were some action items they wanted to see move forward.
Yeah, no, that's a great question. I love this model. I wish I could say we were that organized and but we weren't. I think that, you know, our goal is to improve patient outcomes and improve equity, and to improve our diversity and inclusion and culture of inclusion in our departments. So those are very, very broad goals. And then, you know, we kind of developed bite-sized projects underneath each of those headings. You know, some of the projects that we kicked off didn't go anywhere, and some of them did. I really like this. This is much more organized. So I actually screenshotted it so we can continue to use this in the future.
Great. Well, thank you. Well, we thank you so much for your presentation and for coming to talk to us, because it's been a journey, and it's going to continue to be a journey. We know that. We're very well aware of it. I had a conversation actually with some colleagues from the California PQC around them starting their equity journey. And, you know, everyone's statements are, this isn't like the other bundles. And it's partly because it feels, there's an emotion attached to it that feels very different than when we're thinking in our clinical brains and just thinking about hemorrhage, hypertension, et cetera. So we really appreciate, you know, just how much thought you put into it. And actually, I really like that you hired and brought in a consultant to work with the team and do some education for the department. So thank you so much for all of that.
You're welcome. Thank you so much for having me. I did just want to acknowledge that the only reason we've gotten this far in our work is because we have had such supportive nursing leadership who has been on board with us from the beginning. We've had a very supportive chair and a very supportive maternity center director. So folks who haven't put together an equity team yet, I would say that, you know, the first steps are really to start building relationships with leadership and making sure that they have buy-in, because that was key in getting us this far.
No, I understand that completely, and I completely agree. So I'll turn everyone's attention for additional comments or questions. If you want to put them in the chat, we'll have that there to send to Dr. Ireland if we want to, you know, continue conversations, but we'll love to have you back in the future again. So thank you. If you go back, actually, one slide, Kaylee. I just wanted to point out to everybody an example of a complete aim statement related to your equity goals could be, by June 2023, our unit will prevent denial and delay in diagnosis and management of OB hemorrhage by increasing the percentage of births using QBL to measure blood loss from X, whatever your percentage is currently, 25%, let's say, to 100%. And by implementing changes developed with our team, including 2 patient representatives with lived experience. And so this is something that helps. This could be a practice that the teams, your equity group does, so that you can think through what are the specific things you want to accomplish, what's measurable, what's achievable, because it can be overwhelming otherwise. Again, focusing in on our equity goal allows us to not feel so overwhelmed by the larger picture of what we're talking about when we bring up the word racism, which can feel heavy. We can go to the next slide. And this is just included, and we'll talk more about this in our next webinar, the Donabedian model, which our healthcare structures, the process, and the outcomes is the trajectory of what we're thinking about when we want to move someone through from the beginning of their pregnancy, prenatal care, labor and delivery, and postpartum, on the other side to having had good structures in place, good processes for timely treatment and respectful care, and then no SMM if we can prevent, of course, but we know that some is preventable and some will happen. But the goal is to eliminate preventable SMM and act as when we can in a timely fashion. All right, I want to turn it over to Kaylee to wrap up and go over the announcements. And I'm looking forward to seeing everybody again next month too.
Thank you, Audra, and thank you, Dr. Ireland, for those wonderful presentations. If you all can hang on with us for 5 more minutes, we have several announcements for some really exciting things to come in the new year. So a reminder, our next webinar will be on Tuesday, January 17th from 12 to 1 Eastern. We'll have a guest speaker presentation on REAL, that's race, ethnicity, and language data utilization. And we're also very excited to share that we've been working really hard in the background to secure continuing education credits for these webinars, and those are now available. So if you go to our webpage, and by the way, Anna will be putting links in the chat to all of the events and resources that I'm going to talk about. Thank you, Anna. If you go to our webpage with our webinar archive, you'll now see links that say credit claim page. So for each webinar that you have attended or watched the recording for, you're eligible to take a brief post-test and receive a certificate of credit. So we encourage you all to do that, and these credits are free. So credits are already available for the first 3 webinars in this series, and moving forward, you can expect credits to go live around 2 weeks after the webinar date. We have so many great resources to share. So our equity bundle resources and toolkit are being continuously updated. So be sure to check out that webpage from time to time. And for upcoming events, we are so excited to share that our partners at AIM and NicheQ are doing another 2 cohorts of their QI community of learning. So this is a monthly space for AIM state teams, as well as now they're opening it up to hospital teams to come together and hear QI educational presentations and discussions with professionals. So if you are new to your institution, new to QI, or would love a chance to brush up on your knowledge, this would be a great opportunity. It's free. Registration is open now until January 6th for the first cohort. And then the second cohort registration will open in April. We also were sent a job opportunity that we were asked to share with our Penguin network. The Welcome Family program in Springfield and Holyoke are looking for a full or part-time maternal and child health nurse to offer universal one-on-one home visits to moms and newborns. I'll also be sending this information out in an email after the webinar, and Anna is also posting links in the chat for you all to share if you know anybody who might be interested. If you have been part of Penguin's opioid work in the past, or you're currently stepping into that arena, one of our colleagues with the Perinatal Opioid Project sent us this webinar from the University of California, San Francisco, called Doing Right at Birth. It's on January 19th, and it will bring together experts in law, health, and lived experience to discuss or to provide training on aspects of reporting birthing people who use drugs to the child welfare system. This was a webinar as part of a series, and the person who sent this to us said that the previous events were very valuable. So we encourage you to join. Our partners at the Institute for Perinatal Quality Improvement are doing their annual 28-day anti-racism challenge coming up in February. This is a great challenge. It's so easy to do. Once you register, you'll get daily emails in February with prompts, reflections, videos, small actions you can take to advance your personal anti-racism. And we've gotten feedback before from Massachusetts hospitals who've said that whole teams have signed up for this challenge in the past, and they discuss the prompts as part of their daily huddles. So we think that's a wonderful idea for taking advantage of this. Also from PQI, upcoming Speak Up Implicit and Explicit Racial Bias Education for 2023. There will be a free champions training on May 3rd and 10th from 8:30 to 12 Eastern. As well as we have ambassador trainings are going to become available next year. So for those of you who have already taken a champion training and would like to build on your education, ambassador trainings will be on April 13th and May 25th. And these will be national trainings, but there will be room for 75 Massachusetts champions to attend for free on each date. CE credits will be available, and Registration is being set up for these events currently, but we will share that via email as soon as it's available. It's going to be a busy year next year. Penguin is having our first of 2 summits next year in person on April 12th at the 4 Point Sheraton in Norwood. This our previous summits have focused mostly on the Perinatal Opioid Project, and we're so excited to expand the scope of this summit to include equity and our CDC grant projects that Audra mentioned earlier in the webinar. So please save that date. And again, registration information will be shared soon via email. This is just a slide to remind you of the previous Penguin PQI Equity webinar series that Audra mentioned earlier as well. And Anna is putting the links in the chat. These webinars were created to help you complete structure measures. So again, going to flag that first one there, webinar 1, creating anti-racism statements for perinatal facilities. That'll be extremely helpful for those of you who would like to follow in UMass's example from today. And finally, we do have free CME and CEU available for previous bundle webinar series. So if you joined the obstetric hemorrhage or severe hypertension webinar series, or you've watched those recordings recently, you're eligible to receive credit. Again, you take a 5-question post-test through Boston University and you'll receive a certificate. And just please note that there are expiration dates to these opportunities. Hemorrhage expires mid-January, but if there is enough interest, then we will pursue renewing that accreditation. That's all I have. And I just want to say thank you to everybody for attending today on holiday and right before a holiday. So thank you for giving us your time, and safe travels to everybody, and Happy New Year.
Thanks, everyone. Thank you. Great job, Kaylee.